So let me get this opened up. There we go. So hopefully everybody can see the slides. This is the information for CMEs. If you have any questions, just reach out to Rana. I'm sure she can answer those for you. I or any of the other hub members do not have anything to disclose or a financial arrangement related to the content of this activity. What I'm going to be talking about today, and I know many of you are not therapy providers, so I'm going to try to provide kind of an overview of what CBT is and go over some specific relapse prevention techniques that fall under the CBT umbrella. So that way, if you're referring to that treatment, or if you're a psychiatrist and you're, or psychiatric nurse practitioner who's wanting to go on to get additional training in this, you have kind of an idea of what this type of modality would look like in terms of a psychosocial intervention. So I'm going to cover sort of those basic components of CBT, and then I want to give you really briefly a snippet of what some of the interventions that fall under the relapse prevention category would look like. So I'm going to talk about trigger and trigger identification, urge and craving management, and then behavioral contingencies. So before I introduce what CBT is in a nutshell, I think it's helpful to sort of think about where does it fall in terms of a patient's recovery journey. At what point would it be beneficial for them to get involved in cognitive behavior therapy? So most people have seen this or are somewhat familiar with the stages of change model, and you can see that it goes from pre-contemplation through maintenance. Now, relapse prevention skills that we're going to be covering today that fall under the CBT header really belong in this action into maintenance category. They're not that they can be utilized for people that are in that pre-contemplation contemplation area, but in terms of we might use them more with a harm reduction emphasis. So trying to get people to decrease or use differently in the service of improved health. That's different than some of the techniques that I'm going to go over today, which fall under the relapse prevention category. So here's another kind of way of thinking about it. When people are early in treatment or they're highly symptomatic, they're falling in that pre-contemplation to contemplation area, then really harm reduction techniques are going to be recommended. Now, once they move into this sort of action and planning, we can use general cognitive behavioral therapy, which tends to be somewhere between 12 to 16 weekly sessions with homework in between, focused on identifying all of the things that are causing them to use and apply specific skills to decrease that use to abstinent levels. There's a number of CBT manuals that could be used at that point. And then we follow it up with relapse prevention, which also falls under the CBT header, but has some specific techniques that I'm going to talk about today. So what I'm hoping for people to walk away with is in general, what is CBT? So when I'm referring patients to it, or when I'm thinking about learning this for myself, understanding that it is a talk therapy that really has a number of techniques that are geared to connect thoughts, feelings, and behaviors. And it's very transparent in that we want patients to learn these techniques so that they are no longer reliant on the therapist to practice them. So it's very pragmatic, and it has really good evidence for treating addiction. There's been numerous studies that have used CBT models for almost every type of substance and patients that are duly diagnosed. So they have a mental health condition and a substance use issue. The nice thing about CBT is even if you're not implementing the full protocol, it is highly flexible. And so you could pull out different techniques, like some of the ones I'm going to talk to you today, and you can implement that in many different settings. So a lot of integrated psychologists or behavioral therapists will use different CBT techniques in a primary care setting or an emergency room or a setting where they only really have maybe 15 to 20 minutes with the patient, but they want to teach them something so that they can then go and implement it for improved health. In general, CBT is really intended to be short-term and highly focused. So this is not something that they should be doing for years on end. It's really, like I said, about 3 to 6 months is your average protocol that you're going to apply a CBT focused therapy for. And the nice thing about it is it does work in conjunction with medication or even integrating other therapy modalities. So again, highly flexible. This is called the CBT Triad, and this really, I think, helps give a visual to explain when I'm doing CBT with someone, what am I really teaching them? So we're teaching them the relationship between I have something happen in the environment, so that's the activating trigger. Something happens, and then that causes a thought or a cognition. Oftentimes that thought is not completely realistic or helpful. So that could be an unhelpful or what's called a distorted cognition. So then that thought triggers an emotion and a behavior, and that's connected by what my body does in response to either the emotion or the behavior. And you can see in this cycle that all of these arrows are bidirectional. So typically the environmental trigger will cause a thought. Patients are not always aware of what that thought is. It's called an automatic thought. They're much more aware of the emotion that follows or the action, the behavior that they take. So what we work with in CBT is helping to slow this cycle down and teach patients the ability to understand, okay, what triggered me? What did I say to myself? What was the emotion that I felt, whether that was what's called either a manufactured emotion or a natural emotion. So if it's manufactured, that means it's driven by what I said to myself. And then what was the behavior, the action that I engaged in as a result of that emotion, and how helpful or unhelpful was that behavior? So what are the short-term and long-term consequences? Once they understand this cycle and all of the different ways that they can intervene with it, then they can start to be empowered to make changes in their life. And this is particularly helpful when it comes to addiction or use behaviors. So rather than just saying, okay, the plan is to stop, it's helping them to backtrack and go all the way to that initial environmental trigger, because there's probably 25 different points in which they could intervene to actually change course and not engage in the use behavior itself. So CBT sessions are different than supportive therapy or humanistic psychotherapy, psychodynamic psychotherapy, in that they are really very structured and the clinician assumes an active stance. So this is not the type of treatment where a patient's going to come in and the therapist is going to say, tell me about your week. They're going to start with an agenda where they're going to have specific things and activities that they're going to cover. There's a rule that we follow in CBT. So most sessions are 55 to 60 minutes, and we divide that session into 20 sub-sessions. Even though we want to listen and voice acceptance, those are brief interventions that are used in the service of making sure that we are staying on track with what that agenda is and covering the things that need to be covered in those 20-minute sub-sessions. So we're trying to get that balance between being overly passive and non-directive and being overly rigid and machine-like. It's somewhere in between. When we come in, how are you doing? This is what we're going to cover today. We're going to talk about this, this, and this, and then we'll practice, and then we'll assign some work for you to do at home. So the 20-20 rule breaks down like this. The first 20 minutes is where we set the stage. So you always start with an agenda. Today we're going to talk about this. You might briefly ask them to talk about current concerns, so just the past week, and identify which category those might fall into within that triad that I just showed you. We want to also talk about their substance use or craving since the last session, because that's a lot of the work that we're doing, especially early on, is their actual use behavior with logging and tracking. And I'm going to show you that in a minute. And then we want to review any homework or practice that was assigned. What makes CBT slightly different from other interventions is the homework piece is really, really important. And in fact, if patients are not doing the homework or the practice between sessions, then they're really not going to benefit that much from CBT. And that's one of the things that we talk to patients about before they start, is really being willing and able to do that practice in between the sessions with the therapist. The second 20 minutes is where we would introduce a new technique. So we really don't go over more than one skill per weekly session. So once we've done all of these things, which again takes 15 to 20 minutes, then we say, okay, now we're going to practice a new thing. This is the skill that we're going to go over. This is how it relates to those current concerns that you've talked about this week. We want to make sure that we're engaging with the patient at their reading level, at kind of meeting them where they're at in terms of understanding the technique, because if they don't understand why this is going to benefit them, then they're not likely to implement it. And then we wrap up that 20-minute session by actually practicing the skill, either through a role play, going over the worksheet, doing examples with them, whatever it may be. And then the last 20 minutes is where we do some checking for understanding. What is their reaction to that technique? How likely are they to use it? You assign practice or homework. How are they going to continue practicing that skill for the next week, and log it and track it and bring that back for the following session? And then you go over high-risk situation planning, which I'm going to show you an example of that. You always want to wrap up with high-risk situation planning, because we're teaching them the ability to be able to look down the road just a little bit, just over the next couple of days, what's coming up that's potentially triggering to the point where they're likely to use, and coming up with plans to prevent that. And so that's something that you always do at the end of a CBT for substance use session. What are some of the difficulties with implementing CBT? Well, it can be difficult to stay focused, especially when patients have a whole host of issues that they're bringing to the table, which is why I think if you're doing traditional CBT, you're going to want to wait until a patient has at least decreased to the point where they are stable enough to attend a scheduled appointment. That's kind of your benchmark. If they're no showing a whole heck of a lot, they have issues with housing, with having, you know, regular sort of safety and stability in their life, they're not going to be very successful at CBT, and it's going to be really hard for you as the therapist to stay focused on those specific techniques. So you really need to do a bit more of that supportive case management, harm reduction approach, even motivational interviewing, until patients are stable-ish, and then you can start to teach them these skills, because that can really, really interfere with keeping people on task with that agenda. You also will need to problem solve why they may not be doing practice, and really get concrete. Where are they going to keep their folder with those homework sheets? What time of day are they going to do it? What day are they going to do it? Helping them put an alarm in their phone, really problem solving, so that there aren't any barriers for doing that practice. Because again, if they're not doing the practice in between sessions, they're only getting a fraction of what CBT has to offer in terms of symptom reduction and benefit. The other thing is, if you have started with one form of work with a patient, so let's say you started with more of a solution-focused, supportive approach, and then you switch to CBT, that can be really hard on patients to shift into that new pattern, because this is a different type of therapy. And so if you're referring for CBT, just preparing patients that this is going to be different from more of that supportive case management type therapy that they may have received in the past. And then making sure that there's enough flexibility so that you're not perceived as kind of like this robot, this uncaring person that's just like, well, we need to stay to our agenda, that you have the ability to roll with what's happening, but still bring it back around to the task at hand. A couple other things to keep in mind with CBT, especially when you're thinking about, you know, referring to a therapist or doing this yourself, is the importance of repetition. Habits around drug use are deeply, deeply ingrained. They don't change quickly. And so learning a new approach or changing that habit is going to take time and lots of practice. And so preparing patients for the fact that they're going to try and maybe not be so successful, and then we keep trying, and it's iterative. Every time you try, you get a little bit better and a little bit closer, and that habit starts to shift, but it's not going to be a 180 overnight. And the therapist needs to remember that too, and not be afraid to repeat. What you might have to do the same technique multiple times in multiple ways for the patient or the client to really connect with it. The other thing is, chronic substance use can affect cognitive ability, memory, concentration, other things that are necessary to do the kind of thought-changing work that's part of CBT, and to keep track of things like worksheets or stay organized. And so we have to kind of help people to structure that so that they can be successful. And it's okay to totally repeat entire sessions or parts of sessions. Really, you just want to meet them where they're at and do what's needed. What's important is that they learn the skill. So however many times it needs to be repeated for them to learn the skill, that's what you do. Another important piece is to always give a clear rationale. CBT is intended to be pragmatic and transparent. So again, we want them to be their own therapist. We want them to be practicing it, not to be dependent on coming to us to do it. And so if we're not providing the why you should practice this skill, they're not likely to implement it or even know how beneficial it's going to be. So we always have to stress, this is why it would be helpful. This is how it's going to benefit you. And then we get buy-in to practice. And another important thing is that we are monitoring. So to do CBT well, you really have to be pretty organized yourself. You have to do a lot of follow-up, and you have to make sure that you're checking in on any homework that was assigned, that you're collecting those logs and going over them as part of your work together. Because if you ask them to do it and then you don't follow up, well, then it is the opposite of a reinforcer, right? It's the absence of providing reinforcement for that behavior that we want to see more of. And so we're going to see less of that behavior. They're going to not do those things. And then lastly, we want to praise approximations. It's really important to understand that people change. We all change slowly and in those little steps, right? And so we want to praise every small attempt that happens, even if they didn't complete the whole assignment the way it was intended. Did they do any of it? Did they just bring the worksheet back? That's enough. And we can highlight any helpful or healthy change and reinforce that so it becomes a really positive feedback loop for them to want to come and do more and more and more over time. There are some major obstacles to doing CBT, and that has to do with really the amount of avoidance that the substance use disorder population comes into session with. There really tends to be a lot of experiential avoidance, emotional avoidance, and homework and things like that can really fall to the wayside. And so that needs to become a major priority for CBT therapists to make sure that they're problem solving and working through that and helping for patients to really connect with why this is going to be beneficial and how this is going to help them and why it could be meaningful to push themselves in the short term to have that long-term benefit. How you structure, especially using that 20-20 rule, can be really helpful. So the next 5 to 10 minutes, I want to go over some relapse prevention techniques that fall under the CBT umbrella so that you can kind of get a flavor for what this work would look like and how it would apply to patients once they've sort of established some positive change. How do they maintain that? And one of the main things that we do is trigger identification and teaching patients how to understand their external and internal triggers, which cause that urge to use or that craving to use. So something happens, either it's an emotion that's internal or an experience that's internal, or something happens external, like a stress or an environment that causes a thought that is directly connected to an urge or a craving, which is directly connected to the use behavior. So you can see, because this is linear and these things are connected, if we can intervene at the level of trigger, then we can actually stop that whole cascade. So explaining to patients that they have hundreds and hundreds of environmental stimuli that are connected to that use behavior, it's going to take time to extinguish that. Just like it took time for them to develop those connections. So we need to make an exhaustive list of all of their triggers and come up with a plan of what they can avoid and what can't they avoid. And if they can't avoid the trigger, how are they going to interact with it in a way that doesn't cause that use behavior? So, so one of the ways that we do this is using what's called a functional analysis that goes over the drug set and setting and the consequences. And you can use this throughout the course of treatment. So here's an example. So you can see you've got triggers, both internal and external, and then it goes through some of the set and setting component of the drug. And then it identifies that value set and some of those positive concepts. What is it doing for them now? And what is it actually taking away from them? And this can open up a really, really great conversation to help people start to think through, how do I stop at that level of the trigger before it gets to the use? Another technique that is very effective is the application of behavioral contingencies. And so that's understanding that people respond to consequences, both positive and negative. And this has been shown repeatedly. The thing that's important to know, punishment works, sanctions work, guilting people, getting upset with people, those things do work, but rewards work so much better. And they actually have more of a long-lasting impact in terms of behavior change. So when we're working with patients, it's sort of like you ignore the things that aren't going so well, and you really, really reinforce the things that are going well. So it can be helpful in terms of your work to identify, okay, what are the behaviors that I want to see more of? Is it attendance? Is it a decrease in drug use during treatment? And then coming up with a way to reinforce that. It could be a verbal reinforcement. It could be like, hey, that's awesome. I'm so glad that you did that. Or it could actually be something like our built-in set with methadone take-homes, right, is a reinforcer in and of itself. Having some sort of opportunity or contingency management program, or even sobriety chip that you could provide for people, providing those public acknowledgements, whatever that may be, to reinforce the behaviors that you want to see more of. This can be extremely helpful for helping patients to shift, especially when they have lower internal motivation. One technique that we use in CBT to help build some of that internal motivation is to boost the number of reinforcers to no use. And so using something like an alternatives to use table. So you'd spend a whole session going over, okay, what is the triggering situation and the positive consequences of using? What are you actually getting reinforced by that use in that setting? And then what would be an alternative that would be a similar or equal reinforcer that you could plan ahead? So if I know I'm going to be going to this party and I'm likely to be triggered to use, these are the things that I would get out of it. I'd have less social anxiety. I'd be able to dance more freely or whatnot, or join in with my friends. Here's some other alternatives that we can come up with that you could do instead of that would be equally satisfying, because we don't want to encourage people to just remove something. They need to substitute it to be successful. So an alternatives to use table is one way of building in those behavioral contingencies. And then urge management is another technique that you absolutely want to cover with patients with substance use disorder. This is going from that identifying triggers into that next layer, which is the connection between I'm triggered, I say something to myself, and then I have a craving or an urge to use. So understanding that connection between the thought and the behavior, that there's something in between called an urge or a craving, you can intervene at that level too. And we want to start by teaching logging skills. So having people write down dates and situations when the craving's occurring, rating it between 1 and 100, or putting some numerical rating on it. And then what do they do in that? And so I'm giving you a couple examples of different urge or use logs that we would use to monitor and have those discussions. And then teaching the technique of urge surfing, which is helping patients to understand that they don't have to succumb to an urge when it's present. It's just a thought. They don't have to do anything with it. And in fact, there's a number of techniques that they can apply to distract themselves from it, which will be really helpful in riding out that urge. So thinking of it as, it's a lot easier to surf on top of the waves than it is to be riding underneath them, right? If you're all tossed around by the ocean, that's going to be really difficult to stay afloat, versus if you can float above it, you can kind of navigate rough water when it shows up. And so we do a lot of work here, usually takes 2 to 3 sessions to teach people how to practice urge surfing. But a lot of it is education about what are these types of thoughts, what do they look like for them, how long do they last? They typically only last about 20 to 30 minutes. And then what can they do to manage it? Because every time they manage an urge without acting on it, it's going to get weaker over time, which is why we see improvement once people have some established abstinence, or even have really decreased their use. We see just progress over time, because those urges are not getting reinforced regularly. Now, the last technique that I want to go over, because I mentioned is at the end of every good CBT session when we're doing substance use work, is high-risk situation planning. And you can think about this like, this is our emergency exit strategy. So every place you work, you have to know where your fire exits are. We have those drills that we have to do to practice. Why is that? It's so in case of an emergency, we know what to do. We know how to stay calm and where we're supposed to go, and we've practiced it. It becomes routine. Now, with patients that aren't used to scheduling, they don't have a lot of these skills, they're going to be really vulnerable in a high-risk situation. So this is a situation where they're very likely to get triggered and they're likely to have exposure to that substance and are likely to use. So we want them to come up with a plan. So educating patients and working through what is a high risk situation for them and what is a low risk situation for them. How often are they in these two categories, and starting to shift that balance. So they're spending a lot more time in low risk situations and a lot less time in high risk situations. How we can start to do this is at the end of every session, you put together a plan. What's coming up in this next week? So you write down the situation, and then you have them come up with at least 3 different ways that they're going to handle that situation without using. They're not always going to be successful at applying these plans, but the cool thing is they've actually thought it through. So they have it in the back of their mind, versus if they're just waiting to see, well, you know, maybe I'll do okay. Who knows how I'll handle it? Let's just hope that it goes well. That's not a very good plan. We wouldn't want to do that with, you know, with our fire exits. We need to have a plan, and we need to know what we're going to do and how we're going to handle it. So this is a way of putting that into writing and practicing this every single week to come up with what's coming up for you and how are you going to navigate that to keep your recovery goals in check. So you really need to do this weekly with them, and you can have them start to practice on their own, doing it daily, even coming up with, okay, every morning before I go out into the world, before I talk to anybody, I'm going to come up with what is my plan and how I'm going to use it, where I'm going to keep it. Am I going to put it on my phone? Am I going to keep a copy in my wallet? So that they're more likely to be able to access it when needed. Okay, so we're right at 12:33. Any quick questions before we move on to the case?